Wonderful. Hi, everyone. Thank you for joining us today for a preoperative testing work group. I look forward to facilitating this work group for you all today. So today's pre-op testing work group will feature a presentation by Whitney Soule. Whitney Soule has worked at Munson Healthcare Cadillac Hospital as a nursing quality coordinator for the past 2 years. She holds a BSN from Ferris State University. And before working in quality, worked in the surgery department in the PACU, as well as the ICU and critical care. She has been involved with MSQC for her hospital for the past 2 years. Thank you, Whitney, for being here today to present on Munson Healthcare Cadillac Hospital's successful efforts to reduce pre-op testing before low-risk surgeries. And then after Whitney's presentation, Janice Stewart of MVC is going to provide some updates on a new preoperative testing website called rightsizetesting.org, developed by MSQC, MProve, and MVC. And we'll also put some feedback on a new PCP resource that is in its development. So before you begin your presentation, Whitney, I'm going to review a few housekeeping items. First, the session is being recorded. The slides and the recording will be shared with all attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Whitney and Jenna's presentations for some designated Q&A. And then lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided in the chat at the end of the work group, as well as in an email sent following the work group. That would be greatly appreciated. And for hospitals participating in P4P who would like to receive credit for this work group, the survey is mandatory. So as a reminder, please note the one hospital that you are attending on behalf of so that you can appropriately receive credit. And please complete this survey once for this work group. Without further ado, I will pass it over to Whitney. Thanks so much, Whitney.
All right, thank you. Hi, everyone. I'm Whitney. Let me share my screen here. Okay. There we go. All right. So, like she said, my name is Whitney. I work at Munson Healthcare Cadillac Hospital. And we, for the last 2 years, have worked on the preoperative testing project. And we've really loved this project. It's been a great one for our hospital. To start, I have no financial disclosures. And when MSQC gave us the 3 projects to pick from, this project really just stood out to us. We felt we could make the most improvement in our hospital with cutting down on our preoperative testing, as we were kind of a culprit and like to order everything and just to be safe. So this is a project our head of anesthesia has been wanting to do for a while. And so this just kind of gave us the push to do that. And where we could really help make some positive changes for our patients. Our goal was to reduce the number of tests administered to our low-risk patients before their surgery, as is everybody's goal with this project. So we were kind of excited to get started on it last year. First, we had to come up with a team. Our preoperative testing team comprises of our surgeon champion, who is wonderful. And I will say that I kind of luck out in that I have a really wonderful team. They're passionate about what they do. They're hardworking. Anything I ask of them, they're willing to do it. So that really has been a blessing to me. So we have our surgeon champion. We have our charge nurse for our pre-op and OR staff, as well as our post-op staff as well. Our head of education for the surgical department, our head of our preoperative, or excuse me, our pre-admission testing, our head of anesthesia, and our nurse navigator. Someone you might want to add in there, and your hospital is maybe your surgical manager. They might be a really good person to have in that team as well. For our hospital, this team works really well. So kind of the roles and responsibilities of each of these people, they're all really important roles. The surgeon champion, they're responsible for engaging the other surgeons, bringing the information back to them, and making sure they're on board with the project as well. We, at our hospital, our surgeons don't order a lot of tests before surgery, so they didn't really have to change anything they were doing ahead of time. They kind of already were, anesthesia was the big one that was ordering tests ahead of time, not our surgeons. So they didn't really have to change anything within this project. For our charge nurse for the pre-op and OR staff, they're making sure all the processes are working within the department. They're going between all the different departments, and they're kind of like the glue in this project, making sure it's working, and they get to see it firsthand every day. Our head of education, they're responsible for educating the post-op staff, the OR staff, as well as the new staff that come in. They educate them on processes and policies as well as follow-up. So, not just sending it out in an email. They go and make sure that staff understands the new information given to them or the new policies, as well as they meet once a month on Fridays and go over education there as well. Our head of our pre-admission testing, they're in charge of education for all of the PAT staff, the management of the policies and procedures in the PAT department. So they're a really big role in that. For our hospital might be different in a little bigger hospital. And I will say we're a rural hospital, so we are a 49-bed hospital with 5 ORs. So we are not big by any means. We do put a lot of patients through our ORs for the size we are, but we are definitely small. So it might look different in a larger hospital. But this project, everything kind of goes through our PAT first. So they're a really important part of the project. Head of anesthesia, they're responsible for engaging and communicating all this information back to their other anesthesia providers. Again, super big, important role, because our anesthesia was not on board when we started this project. So Rob, our anesthesia guy, he was kind of my lifeline to them. And then lastly, our nurse navigator, they help bridge the gap between anesthesia, PAT, pre and post-op staff, and kind of everybody that just hold it all together. So those were the 6 people in our team that helped make this project work. I'll give you, now this is kind of busy, and it's just a snippet of one of our old protocols before we started the preoperative testing project. This was our old protocol that was put into place. It says it was looked at in 22, but really we just added one thing to it. A lot of the information in there wasn't looked at wasn't changed, updated, I should say. It was looked at, but not updated in a while, and really needed to be. It was kind of busy. There's a lot of information in there. And we really looked at the patient history and comorbidities on how to pick our testing for our patients. That is one of the biggest changes that we made, was instead of looking at their history, we now look at their ASA class. That was never a factor before. So like, let's say our patient with hypertension, doesn't matter if you're stable or if you're taking medication or not taking medication, we would order a CBC, BMP, EKG. So it was just kind of one size fits all approach that we had. Good intentions for sure, but that's kind of how we did it. Same with our smokers. If you were over 50, it doesn't matter. It does say within 30 days, but really we were testing people that had quit a couple months prior. We were still giving them an EKG. So this was our old way of doing it, and there's pages and pages in our protocol. This is just a little snippet to give you an idea of what ours looked like before the project. So where were we falling short? Well, we were following an outdated protocol. I'm not really realizing it. We had a one size fits all approach. We were just, you have hypertension, you're getting a test. It doesn't matter if you're not currently being treated for it or if you're not taking medication for it. We just kind of threw everybody into a category instead of looking at the patient individually at what they need. We were over ordering our EKGs, CBCs, and BMPs. I'm not sure how it looks at your hospital, but we love those tests here. So, especially on our ASA 1 and 2 patients is where we were over ordering them. Probably under ordering them on our 3s and 4s. And we weren't following evidence-based practice, again, not knowing. So changes we administered, we revamped our preoperative protocol for all our surgeries. We made a decision as a team that while MSQC brought this to our attention and it's a project we're doing for them or doing with them, we really needed to change all of our surgeries in order for it to be successful, not just the surgeries that qualify for MSQC. We also, our protocols tailored to each ASA class instead of their history. And we discontinued ordering unnecessary tests on all our patients. You know, some of our providers were in the mindset of, well, let's just order it to be safe. And that's really not what we should have been doing. And we decided to follow the NICE guidelines or the National Institute for Health and Care Excellence. We follow their guidelines now on our protocol. So our focus for our tests, very similar for 2023 as 2024, just a couple changes. Last year we were focused on the ASA 1, 2, and 3 classes. Our breast lumpectomies, our lap choles, our minor hernias. And we really wanted to reduce the number of preoperative tests being ordered within these classes and surgeries. This year, we're focusing on 1s and 2s because that's our 2s are where we fell out the most. And all of our minor procedures, not just those 3 surgeries listed above, but we are still obviously focusing on those as well. This tool I love, was given to us, you know, MSQC provided and MVC provided this tool that we used to get our protocol started. And if you haven't used it, I would. We've obviously have expanded upon this, but this is where we got started when we were looking at redoing our protocol. And it's very easy to follow, makes sense, and so I would recommend it to anybody. The other thing we looked at was suggested tests for patients undergoing low-risk surgeries that are not your 1s and 2s, but your ASA 3s and above. And that was helpful to anesthesia as well, just to kind of see, okay, yes, we should be ordering these, or no, we shouldn't. So we also use this chart as well to map out our protocol. Barriers. Oh, we had a ton. We had a ton of barriers. So if you're in that boat, do not feel alone. If you feel like you're never going to hit the target, don't feel alone. If you would have asked me all last year, or even in December, are you going to hit your target? I'd be like, I don't think so. But one of our biggest barriers was engagement and buy-in from anesthesia. You know, I love our anesthesia providers. Some of them have been here 30 to 40 years, and they kind of got our surgery department underway. Like they are kind of, we call them the founding fathers of our surgical department. So they're very good at what they do, but not always changing with the seasons. So getting buy-in from them was our most difficult barrier, I would say. Our CRNAs right away. And anesthesiologist took a little more convincing, but we did. Turnover in staff. You know, probably like any other hospital right now, we've had a ton of turnover within our surgeons, nurses, PCAs, you name it, we've had turnover. So just educating the new ones coming in, making sure they understand protocols has been difficult. Time. A year sounds like a long time for a project, but if you move like our hospital, we kind of sometimes move in sloth time. And even though we start something, you're like, okay, we're gonna do this, and then like months go by and nothing is happening. So the time went by really fast, and it just felt like we didn't have enough to do what we wanted to do. That's why I was really happy when we could do this project again for a second year. Communication. This is one thing I learned a ton on this year was if someone says they're going to do it, don't just trust them, but follow up. You know, don't micromanage, but just make sure that they understand and just follow up. So communication was a big was a big barrier as well. I feel like I had one more barrier. But I don't remember it at the moment, so I will skip to the next slide. Our project timeline. So we implemented this actually the last day you could, which was June 30th of 23. And I did actually feel pretty good about it at the time because everybody seemed pretty excited. And it didn't seem like a huge change. You just stop ordering those tests, right? Well, no, that wasn't that easy. And in July, 3 weeks later, when I went down to see how it was going, I asked the staff member, how's the new protocol going? And they said, oh, we're not following that. And I said, oh, okay. And why? And they said, well, we just don't want to, it's confusing. And what was confusing was the other protocol was still set in place, which I did not know. And so staff just didn't know what protocol to follow. So our project failed. It did not go well. And then, so in August, the beginning of August, I held an emergency meeting, which ended up being poor turnout. It was just my boss and myself. So that was very discouraging. A week later, I held another meeting, but this time I included the CNO. And it's amazing people come when the CNO comes. So we had an excellent turnout. We created a new plan. We put it into place. And so I felt positive after that meeting. September, we re-implemented the protocol that we came up with in August. So not feeling quite as encouraged as in June, but still like, okay, we can do this. November, our new protocol was in place. Most of the providers were on board, so that was a win. We did still have some that needed some encouragement and education. And some people just take longer to come to the race, and that's okay. We just gotta not leave them behind. December, our project was doing well. We were seeing the number of tests being ordered coming down. So I did feel very positive. Did I think we were gonna hit our target? No, just because we kind of were late to the game. But everything was running smoothly and it was going well. In January, we decided to continue this project. Because otherwise we felt like it would kind of fall to the wayside and we really needed another year to kind of solidify it into place. We were still working on getting it approved officially. It was in place. It just wasn't through all the avenues it needed to go through yet. So I was still feeling very positive. And then February hit and I had providers, I had staff saying, hey, is this project over yet? Can we go back to the old way? And I was like, no. So re-educated again on the importance of the project and why we're doing it, that it's best for our patients, not just because it's something to do. And so we re-implemented for a third time's the charm, on March 4th of this year. And now it is actually official and part of our policy. So it took us a long time. So if you're feeling like, oh, this is not going to happen, do not be discouraged. Just think of us. And it took us over a year, so it's okay. You can get there. How we started, when we started looking at revamping our discharge instructions, we obviously looked at the NICE guidelines and they broke it into minor, intermediate, and major surgeries. And that was really nice. This is actually a tool that our PAT nurses use. It looks a little different for them, but for these purposes, just so you can see it, they go right to what type of surgery it is. Okay, it's a cholecystectomy, then that's a minor surgery, and then they go to their protocol from there. So this is kind of nice. It separates it into the category of surgeries. And then this is our actual protocol. As you, I don't know if you remember from our other one, but our other one was very busy, a lot of words. This one is simplified, black and white, not as much gray area. And that's really where we were having problems before, is our protocol had a lot of gray area. This one does not, and I love it because now it's not on patient history, it's on ASA class. So let's say they're having that cholecystectomy. Okay, that's a minor surgery. They're ASA 2. Okay, I do not need to order any of these tests. So for our surgical department, our PAT nurses, they are the ones that are deciding the ASA class, which was a big change for us. It's anesthesia, right? Well, don't worry, they're still involved. So after they decide the class, that chart goes to anesthesia, and then they ultimately can change it. So if they feel, nope, this patient is really a 3, or vice versa, or I do really need them to still have an EKG, that's okay. But PAT nurses are just the first to see it, to get stuff rolling and going, and they're the ones who talk to the patient the most before the surgery, and then the anesthesia can always overrule that and change it as needed. So this has really kind of been a blessing. I mean, I know a lot of people were against it at first, but now I have got some positive feedback from the people that were not on board, and said that they really do, it's easier. So that's nice. That was our goal. And also, we don't want to be ordering tests for patients that don't need it. It costs them money. It costs them anxiety, stress. I can't tell you, I worked in PACU before, and how many people come out of their surgery, and one of the first things they would say is, why did I get that test and what's wrong with me? And as a nurse, you're like, what? You don't know. So you go check the chart, and you're not sure why they ordered it. And so unnecessary stress and anxiety, they don't need that. And really what was happening at our hospital, not sure if this happens at other ones, but our anesthesia providers were really guilty of, they would come in the day of surgery and say, I want this patient to get a CBC. Lab would come draw it, and then they would take the patient to surgery and not even wait for the test. And that was driving our charge nurse crazy. We have stopped that completely. And if they do that the day of surgery, they have to fill out a form of why they did it so that I can track it. And they're less likely to do that then, because it makes them do more work. So not that I don't want great work for them, but so for this is our baseline. So this is from January to March of 2023 of what we were ordering on our patients. So we were testing at 42% of our patients that went through. We were testing. And as you can see, the majority were ASA 2s, which is crazy. We were testing more our 2s than our 3s. So that was really something we needed to look at. And we're happy this project kind of brought this to light. So baseline to final, this is just another way to look at it. We have January to March in our first chart. And as you can see, for our hospital, we order a lot of BMPs, CBCs, and EKGs. And then it breaks it down into class, which is nice. And then from April through December, those are the tests we like to order here. And the numbers are higher, but this is a longer period of time. So really we were decreasing, even though it doesn't look like it. But again, 23 of our EKGs were ASA 2s. So an area we needed to look at for this year. This is our final that we got in January, our push report, which I love these reports so much. We did bring it down from 42% to 31.47%, which is awesome because I really didn't think we were going to hit it. We were supposed to get to 33, I believe, 0.67%. So we did hit it. But again, our ASA 2 were at 51%. So that was our big focus for this year, is bringing that number down. Our chart over here, we are the blue, Cadillac Hospital is the blue, and then all the other MSQC hospitals that participated in this testing project is the red. And I'd like to point out, when we implemented our project in June, our testing went up. So we had some pushback. We did start to decrease as the fall went on after we re-implemented. November, I can't explain. I'm not quite sure what happened there. I don't know if it's just Thanksgiving. We didn't have as many surgeries going through. I knew we had some surgeons off. So the patients that went through were tested. I have no idea why we were at 100%, but we were. But we brought it back down by December. So kind of how I think we were able to be successful is Well, one, we just never gave up. Like, I was not willing to take no for an answer. I wasn't very well liked sometimes down there, but that's okay. So for your team meeting, you only need to meet twice. We meet monthly. I feel like twice isn't enough. It keeps the fresh in your team's mind when you meet monthly. Otherwise, it kind of feels like it's not as important, which it is. And then we met like in July and August, we met 3 times each month just because we needed to. I wouldn't say you would need to do that if everything's running smoothly, but it was not for us, so we needed to. I round in the surgical department. I go down weekly and I talk with the staff. I don't do it for long. I just, say hi, make my face known so they know who I am. Before I joined MSQC, the quality department, I didn't even know this existed. And I didn't want that to happen. So I go down and I talk to staff, make sure it's working. What do they need help with? Any changes? So that's been really important as well. I use those push reports that MVC gives us. I love those so much because I like to share them with my team. And even though I track stuff on my own, it's just helpful to have these reports. They put them in fancy graphs that I don't do. And so they can see the information and it doesn't lie. So you can say, no, we're not actually hitting target, and it shows them. So I love those reports. And then just follow up, going down, making sure everyone's doing what they're supposed to be doing. Again, not micromanaging, but just following through. So those I think have helped us to be successful. And then our plans and goals, we want to continue improving the efficiency of our pre-op testing protocol that we set in place. And you can even see this year we've had some struggles. Not that it's ever going to be perfect, but we're also going to continue to reduce the number of cases. Our goal is to get down to that 20%. And I feel we can hit that. If we focus on our ASA 1 and 2s, and reducing the EKGs, CVCs, and BMPs ordered. So that's kind of our plans and goals for the year. And that's all I have. So I'm done. Thank you.
Wonderful. Thank you so much, Whitney. Definitely not easy work, but really great. It was really great to hear your story. Kind of the
Thank you.
ongoing process of, education and re-education too, I'm sure. What questions do we have for Whitney today? Looks like we have a question that came through the chat from Amy. Does your hospital have any guidelines regarding HGA1C ordering? Our hospital orders so many of these.
We don't order those a lot. We just look at to see if the patient's had one in the last 3 months. Or excuse me, I want to say it's 6 months. And then if they have, we don't order one. But I wouldn't say we don't really order those a lot, I'll be honest. It's usually the PCPs that are ordering them, and we just look at their results. So
another question from Chris in the chat. Is this being rolled out to the entire Munson system so the learning is shared?
we would like to. I know that Traverse City, so I'm in Cadillac, and Traverse City did this project as well last year. Sorry, my hands on my face. But they're doing a different project this year. So I know when we were looking at revamping our protocol, we looked at a lot of what Traverse City was already doing to kind of be cohesive and do the same thing. We really want to. In terms of the smaller hospitals, we haven't yet, but that's something I want to bring to the team and see if it will be feasible to do that.
Wonderful. Any other questions?
Whitney, wonderful presentation. Thanks for coming and speaking today.
Yeah, thank you so
A
much.
couple questions that I have as a follow-up around anesthesia specifically. So first question, you mentioned that you implemented some changes for the anesthesia folks that were doing day of surgery ordering. Can you talk a little bit more about how you managed that and sort of got them to agree to fill out? You mentioned a form, or they had to do extra paperwork?
Yeah, well, and it's not necessarily extra paperwork. It is on a form that they already have when they fill out. So they do computer work and then they have this form that's in the chart. And I was fine with like a focus note in whatever worked for them. I really didn't care how they did it. But they, as an anesthesia group, agreed on a form that they already have and they write on, there's a little box they can write on if they order EKG, why they're doing that. And the reason I was so adamant about that is at the end of the year, maybe it's for selfish reasons as well, is I have to give analysis of why we ordered something the day of. And because we were so big on that, I wanted to make it a little harder for them to do that. Most people were on board with not ordering the day of, but we had a couple that continued to do it. Rob, our head of anesthesia, I call him our anesthesia champion because he's so wonderful. They really respect him. And so he just went and had a conversation with them and said, I'm not asking, this is what we're gonna do. And they were fine with that. And so now they follow it, but it wasn't anything. It shouldn't add a lot to their plate. They just have to jot down a note, even if they put like an arrow up, high blood pressure, I'm good with that. I just need a reason why. So I hope I answered your question. I'm sorry if I didn't.
Yes, you did 100%. And then my second was that you mentioned that was kind of the group that was the toughest to kind of get on board or engaged. And so I wondered how you managed to kind of turn that tide. Do you remember if there was a specific strategy or light bulb moment where it just sort of began to improve with that group? If there's
I
something
started to show our numbers compared to other hospital numbers, and I think it kind of just was like, oh, like we're other people are doing better than us. I think they're a little competitive, and it kind of hit home like, oh, okay, we're not doing what we should be doing. And then Rob as well, talking to them, kind of put it over the edge because they really respect him, and he goes to a lot of conferences, and he just said, look, this is what everybody in the country is doing. We really, especially in Michigan, we really need to be on board with it. And so they eventually changed, but it took a long time to convince them, for sure.
Thank you.
Looks like we have another couple of questions in the chat from Laura. Can you please share the reference for minor, intermediate, and major surgery? Whitney, if that's something you would be able to share, we'd be happy to include that in the follow-up email.
Yes, for sure.
And then a question from Chris. What communications were made to PCPs who may do the pre-op physicals for patients?
Communications. I don't know if I understand the question. Were made to PCPs who may do the preoperative physicals for patients.
So Whitney, I can add some context.
Okay.
I think quite a few sites have noticed that a significant portion of their pre-op testing orders are actually coming from primary care physicians, either as part of like their physicals or because
Got it.
presenting to a PCP with an issue, a test is ordered and then they get in for surgery, which would be actually appropriate, like diagnostic testing. But I think they're wondering about how do you engage PCPs to get them kind of on the same team?
Oh, yeah. So that's actually an excellent question. Because so far the 2 tests that were ordered this year were from PCPs and not anesthesia, that we fell out on. And so what I did was I sent our new protocol to all the PCP offices, which again, we're in a rural area, so that might be harder in a bigger city, bigger hospital, but I sent our new protocol and just said, this is our new protocol. Obviously, they need to order, if they need to order tests and it's their annual, you got to do that. Like, that's understandable, but just so they're aware of the project, and it actually has help. And PCPs actually thanked us for just letting them know, so they don't order tests that maybe the patient can wait on. But for the most part, I kind of feel like if PCP orders a test, they probably need it. But we just share our project with them so they are aware of what's happening here. Not necessarily to change what they're doing, but just for awareness.
Great. Thank you, Whitney. Does
You're
anyone have any final questions for Whitney before we turn it over to Jana to share a few updates?
Not that I don't want to speak, but I have another question if you don't mind, Whitney.
No, that's fine.
You mentioned that the PAT staff sort of took over like interpreting the protocol, and I think a few sites have at least mentioned to us that there's some confusion about the ASA class and how to interpret that. Did you mention anesthesia is assigning that class on the patient's chart and then it goes to PAT, so they're not having to kind of,
Well.
or how do you navigate that, like them not being certain how to assign the proper
Yes, so this is our biggest puzzle piece to put together, because PAT staff did not feel comfortable picking the ASA class. So anesthesia, they're the ones who came up with this protocol. And this is what they would follow it when they were picking it. Again, you're gonna look at this minor or what surgery they are, classification. Which I did get, we use the National Institute for Health and Care Excellence, so the NICE guidelines, someone asked about that. That was kind of our reference and where we got this information. And then they go to this and so PAT will look at this, they'll look at, okay, they're a minor surgery that falls under, I see what you're saying. Okay.
yeah, how do they know if it's one or two? Or
How
if
do
it's-
they know if it's one or two? Okay, so I didn't actually include all of that, sorry. They have another sheet that goes off that kind of, let's say they have these comorbidities, they would fall under this ASA class. So they have another sheet they look at. For our purposes, I didn't add that, I apologize. But they have a sheet they follow. They come up with a class, and then from there, that chart goes to anesthesia. That's when anesthesia looks at it and either agrees or disagrees. So ultimately, anesthesia is still in the decision-making of the ASA class. They're just picking it initially because we want to either get testing going, and they talk to the patient and gather all the information. So they're kind of the ones who get it started, but anesthesia ultimately has the say in it, if that makes sense.
Definitely. And then we have one other question from Laura in the chat. How do you navigate that hernia is listed under intermediate?
You navigate. Okay, let me go back. Open. So these are our open hernia surgeries. So if they are a laparoscopic hernia, that would be minor. Our opens are considered intermediate, and then with our big abdominal compartment separation, those are our major surgeries. So I don't know if I answered your question. But basically, yes, hernias can be anywhere from minor to major, right? Depending. So the rule of thumb is laparoscopically minor, open, intermediate, and then the big belly surgeries are major.
Wonderful. Thank you. So thank you again, Whitney. It was really great presentation, really great work.
Thank you.
I will take the time now to pass it over to Jana to share some exciting updates with you all, and then we'll conclude the work group. I'm going to share my screen again.
Great, thanks, Christy. So at our last pre-op work group, we mentioned that we have begun a new grant-funded pilot trial study. So there's 3 sites participating this year, and there will be a number, I think over 12 sites we're hoping to add to the study for next year. But we have decided on some new terminology around that project. So a lot of folks in this group may have been to the Wave the Workup website that MSQC and MVC kind of shared previously. And so our group sort of decided to move away from the Wave the Workup language. That was intentional. So now we're saying right size, because kind of sends the message that well, the new language sends the message that no testing isn't appropriate either. It's about finding the right level of testing, and that doesn't mean cutting it entirely. And so that kind of is reflected in the new name and the new branding. Aspire and MPOG are also now going to be partners and involved in developing those materials. And so the Wave the Workup website is still up, but it will be retiring. So we have a new, you can go forward, Christy. We do have a new website that's in development now. There's already a few pages available. The decision tree is up there. A lot of those traditional things that were on the Wave the Workup site have been moved over, but we'll continue to add to it over time. So as this project team continues to develop new resources, the new website is where they will appear. And if there's other items that folks think would be helpful, we'll certainly add that to the site as well. We'll probably have an events page going forward that has the dates and times and registration info for things like this, but also perhaps conferences and other things that are relevant. So just wanted to keep this group updated, since I know that website, it's been promoted quite a bit and it's been useful for people, but it is retiring soon. So I wanted to let you know. And then next slide. So sort of as part of that work, a few sites did reach out to, I believe Pam at MSQC, to kind of express, and we've talked about it even here today, sort of, and the issue around engaging PCPs and what should that look and feel like. So the MPROVE team has been drafting a resource in order to engage those folks. And we're hoping to collect some feedback on sort of early draft around that today. So if you can go to the next, I think it's one more slide, Christy. Yeah, so the package as it's currently developed is, it begins with a template letter. In the masthead, you can insert your logo or, edit the wording as you see fit. But in general, the template letter includes an introduction to what the pre-op testing project is, who are the key partners, and basically, this is what we're working on. Please be aware. Here's some resources enclosed that can help provide some additional detail. And so those additional pages include a frequently asked questions page, which is reflected here on the right. We've also inserted that decision aid that Whitney shared, as well as the testing chart she shared, just that, again, they have the same exact protocol and information that everyone else is operating with. And then some other optional pages that could be included would be if you have recent reports or data, you could always slip that into the back as well and share that. So that's what we're thinking this PCP package will look like. And it will be in a Word format, again, so you can make modifications, make it your own, make edits as you see fit. So I am going to be asking for feedback here using a poll, but if you have other if it's easier for you to enter feedback through the chat, that's completely fine too. Or you could send me, an email, but I prefer it here because you're listening to me right now and you might forget to do it later. So, okay, so I'm going to go ahead and just launch this poll. If you don't mind just providing some feedback on this, this idea around a PCP resource, that would be really, really helpful before we share it out with the rest of the collaborative. Looks like everyone's done with the first two, and some people are maybe still working on the third and fourth, so I'll just give it another minute. Thank you so much for your feedback, everyone. I appreciate it. Okay, I'm gonna go ahead and end the poll. In 3, 2, 1. I just saw a bunch come in just to, like, as I was counting down. So, okay, wonderful. All right. I'm not going to share the results right now. I'll just kind of take it away. We'll look through the feedback and then come back with this group with other updates at the next pre-op work group. I know this is one of the questions, but if you do have things you're experiencing at your site this year as part of the project with MSQC that you think, wow, it would really be helpful to have a resource or a starting point here, certainly we'll ask Whitney to share her reference about minor, intermediate, and major surgeries. I think that's a really useful reference, including the one about ASA class, since a lot of folks are having the same kind of challenges and barriers. So please let us know what those things are and what can help you while the MProve team is kind of working on this. And we can use their talents to help everyone. So, okay, thanks, Christy.
Thanks, Jana. Does anyone have any questions regarding anything that Jana just went over? Okay, wonderful. I think we can go ahead and go through our
We
last
have
few.
one. Go ahead, Laura.
Okay. Wait for Laura's question. Yep, you can come
Yes.
up.
Hello, I have a quick question. I put this in my survey, but I'm really confused about, so for the project, we include repair of anterior abdominal hernias in less than 3 centimeters as part of our project for reduction of preoperative testing. But now I'm really confused seeing Whitney's chart, and it looked like it listed that under intermediate. And in this letter that we're sending to physicians, we're not listing that as our target procedures and tests. So I guess I was just looking for some clarification on, does the scope of our project include anterior wall hernias less than 3 centimeters, or doesn't it?
Laura, I think I need to ask Pam that question because I don't want to
Okay.
speak for the MSQC kind of what counts, what doesn't, at least
Okay.
with the pilot project and the MS, so that these are basically informed by how MVC defines its pre-op testing, because that's how we're evaluating the project using MVC data. So there may be some subtle differences here on a couple of these, and I just want to
Okay.
check with Pam. So I will email Pam and I'll CC you
Okay.
so that you can get some clarification on that.
Because I love Whitney's chart that she gives to PAT, and I think that that's really kind of what we're missing, is like those really hard and fast rules about what's included and what isn't.
Yeah.
But I am starting to notice a little bit of discrepancy between the scope of our project and some of those resources.
Okay. Yeah, that's helpful. Thank you. I'll
Yeah,
follow up with that.
thank you very much.
Thank you for the question. Okay, if we don't have any other questions, I can go ahead and walk through the next few slides to conclude the work group. As you can see in the chat, Jessica just posted the work group survey, so you can access it there. If for some reason you can't access it via the chat, we will be including this link in a follow-up email as well, so you'll be able to get that.
Oh, one note about that. If you are at a Sparrow site, we did recently change the names of the hospitals listed on the survey to reflect the new name changes. So you will not appear in the S's. You now need to go down to University of Michigan Health - Sparrow Lansing, Sparrow Eaton, whatever it is.
Thanks, Jenna. So before we conclude, I just wanted to share the remaining dates of our pre-op testing work group series. So as a reminder, to receive the 0.25 points for attending the pre-op work group series, you must attend all 4 work groups and participate in at least 80% of the session. So the 2 remaining pre-op testing work groups for this series are on August 6th and then November 5th. So we hope to see you there. Then I just wanted to share a few upcoming work groups. We will have a cardiac rehab work group on May 30th, featuring Ascension Borges Hospital, Following that, in the beginning of June, we will be having a post-discharge follow-up work group. And then at the end of June, we will have a rural health work group, which will be featuring the Northern Michigan Opioid Response Consortium. As a reminder, all work groups occur virtually from 12 to 1 p.m.